afternoon, everybody, and welcome to today's presentation. I'll be introducing our speaker today is Dr. Abiza Saka. He's a first-year fellow in the Muhimbili University of Health and Allied Sciences, Interventional Radiology. Today's our journal club, and he would be speaking on finding aspiration biopsy versus core needle biopsy in diagnosing lung cancer. So he's looking at a systematic review. And at the faculty today, whom will be supervising his presentation is our own Dr. Judy. Thank you, Abiza, and you're welcome to start.
Okay, thank you very much. Good afternoon again, once again. So I hope you can hear me well.
Yes, we can, thank you.
Okay, so the paper I'm going to present today is fine needle aspiration biopsy versus the core needle biopsy in diagnosing lung cancer. So it's a systematic review. So before I start talking about the paper, I would like just to mention some few points on the evolution of fine needle aspiration biopsy, also called fine needle aspiration cytology and core needle biopsy. So prior to percutaneous technological advance, open surgical biopsy was the method used to obtain the tissue samples for diagnosis. So the earliest known writings of what can be described as percutaneous needle aspiration dates back to the 10th century AD. So in modern times, fine FNA is traced back to the German physician Kuhn, who described using an exploring needle incorporating a depression at the tip with cutting edges for extracting tissue from a subcutaneous tumor. So it was in the late 1840s, 100 years back. So biopsies were usually performed blindly by using utilizing palpation, anatomical structures, and usual locations of organs to be biopsied prior to the image guided. So this is the paper I'm going to present. It is a paper which was published in February 2012 in the Oncologic Pathology Journal. So introduction, cancer is a leading cause of death, and lung cancer is the most common cause of cancer-related mortality. 1 out of 3 patients in the world die due to lung cancer. Early and accurate diagnosis is the key for optimal treatment of lung cancer patients. Histologic or cytologic confirmation of malignancy is required before treatment. So flexible bronchoscopy has high sensitivity for the diagnosis of central lesions and low sensitivity for the diagnosis of peripheral lesions. So transthoracic needle biopsy is usually performed under imaging guidance for patients with peripheral lesions or in whom flexible bronchoscopy is not possible. So the two techniques currently being used are the FNA and the core needle biopsy. So the sensitivity and specificity of both techniques for diagnosing lung cancer have been reported to be high with acceptable complication rates. So these are just some images of the coaxial technique and the varieties of fine needles. So the question, the objective of this paper was to compare fine needle versus core needle biopsy for diagnostic characteristics and yields for diagnosing lung cancer in patients with lung lesions. So the questions they had asked was, is one technique superior to the other for diagnosing lung cancer? Is there a difference in complication rates between the two techniques? And is one technique better than the other in obtaining samples for molecular marker studies such as mutation analysis or fluorescence in situ hybridization? So the methods, they did a literature search in the span of 20 years from 1990 to 2009 using the Medline and M-based databases. So the study selection criteria, the inclusion criteria were follows. We published full text between 1990 to 2009, systematic reviews, meta-analysis, clinical practice guidelines, and randomized trials. Undiagnosed lung nodule or mass demonstrated on imaging. Provided sufficient data to calculate for both FNA and CNB in lung cancer, and at least one diagnostic characteristic, complication rates, or diagnostic yields for molecular predictive marker studies. And also the stated that the reference standard for final diagnosis was histologic confirmation from wedge biopsy, surgical resection, metastasis, or autopsy, or from clinical follow-up. So the exclusion criteria for this study was recruited patients with a previous or current diagnosis of lung cancer at baseline. Those regarded the biopsy results from FNA or SCNB or both as a part of the reference standard. Performed FNA or CNB on different patient populations. For example, technique chosen according to the size of the lesion, or the study which was published in a language other than English. So the initial search was found from was 122, and after filtering, 70 were excluded after the title and abstract review. And then again, 42 studies were again filtered. So the final, they did the study on 11 studies were finally selected for the systematic review. So the method data analysis was done with a statistical software application. And it was used to compare FNA and CNB for diagnostic characteristics, diagnostic yields, and procedure complications. So these were the three questions that were asked in the objective. So the results for overall diagnostic characteristics, benign versus malignant differentiation of using FNA or CNB. So the sensitivity were similar, and the specificity was also largely similar for both FNA and CNB, and also the accuracy. So for the specific diagnostic characteristics, for identifying the histologic subtype of malignancy or the specific benign diagnosis, the sensitivity were pretty similar. So the difference was in the specificity. For the CNB part, it was more specific for diagnosing the subtypes, and the accuracy was also a bit higher for the CNB. So the results comparing with the fine needle aspiration, core needle did not result in a higher complication rates, pneumothorax or hemoptysis. So this is mainly due to the techniques that people have acquired using the introducer coaxial technique for the core needle biopsy, which reduces complication of pneumothorax as you use a single pass. And for the intrapulmonary hemorrhage and hemoptysis, the autologous blood clot technique and gel foam tract embolization has markedly reduced the complication rates. So compared with fine needle, core needle might have a higher specificity to diagnose specific benign lesions, which was discussed in the discussion part. So the discussion part, the data identified in this systematic review are limited and inconsistent because the studies differed considerably in terms of study design, patient population. As some studies did below 13 years, some of them studied on above 8 years of age, and the lesion sizes. So the lesion sizes they studied was from 3 millimeters to 15 centimeters. Method of procedure guidance and exact procedure technique. So from this paper, no study has yet compared the diagnostic yields of fine needle and of core needle for molecular predictive marker studies in patients with lung lesions. So this was before 2009, where this paper was published in 2012. So in conclusion, the evidence is insufficient to determine whether fine needle aspiration biopsy, core needle biopsy, or combination thereof should be the standard of care for diagnosing lung malignancy in patients with a lung lesion. So they had concluded that it all depends on the institution that are performing these biopsies. So well-designed, good quality studies comparing fine needle aspiration biopsy with core needle biopsy for diagnostic characteristics and yields in diagnosing lung cancer should be encouraged. So this was the paper in 2012. So the recent development, so this the first bullet is a paper which was published in the Cancer Cytopathology, which compared diagnostic efficacy and molecular testing by combined fine needle aspiration and core needle biopsy in patients with a lung nodule. So the patient underwent both a fine needle and core needle biopsy in this study, and it found out that there was fine needle aspiration was a valuable complement to core needle biopsy for molecular testing, potentially reducing patient inconvenience and morbidity associated with repeated lung needle biopsy. And the second paper, which was in 2014, published in the Polish journal, which compared core needle biopsy under CT fluoroscopy guidance and fine needle aspiration. The comparison was diagnostic yield. The study showed that core needle biopsy offers higher diagnostic yield for diagnostic of lung and mediastinal neoplastic disease, and it allows for more precise diagnosis of focal lesions. Okay, thank you.
Thank you very much, Dr. Abiza. So I don't know if there are any questions. I had asked that any comments, any questions. I'm sorry, because of network, Dr. Judy is unable to join us. But if there are any questions, please feel free to unmute and ask any questions if you do have. Dr. Biza, I think that was a very well understood and very detailed presentation. So everybody seems to have understood your presentation very well.
Oh, wow.
And yeah. And there are no, I don't know, there are no questions, but I think I will just give like 2 more minutes or 3 minutes for any questions. So if anybody has any questions, please feel free to unmute and ask.
Good afternoon.
Good afternoon.
No problem.
Yeah, I wanted to ask, my name is Dr. Diana. I wanted to ask if size would be a factor in choosing whether to do fine needle aspiration or to do core needle biopsy. The size of the lesion, sorry.
Dr. Abiza?
Yes, yes.
So someone is asking, Dr. Diana is asking, would size be, would it affect the choice? of whether you're going to do core needle or you're going to do FNA?
So it all depends on the operator comfortability. You can do both of them because in some centers, fine needle is done by the pathologist. So if the size is smaller and if the lesion is deep-seated, they normally consult IR physicians to perform. So for the IR physicians, they see the size of the lesions and what equipment is available and their comfortability, so they would go for either.
Okay, thank you very much. More questions? Anybody has more questions, please ask.
Yeah, ma'am.
Hello. Hello.
Yes, Eric, we can hear you.
Okay. I wanted to add on the question which had been asked on the size of the lesion. From just a simple at our institutions, that whenever we do like a fine needle aspiration, they are like telling us that we always have like cells. So, but when it comes to the treatment which needs like molecular biomarkers, maybe for more specific treatments, at our institutions, they are complaining that fine needle aspiration cannot offer such amount of tissue which will be able to do for further diagnosis. However, from the paper, I've seen like they are using like fine needle aspiration to do like molecular studies, but it's better now to ask from our institutions what are the criteria which or factors which hinder them from performing those molecular studies from fine needle aspirations. That's what's I've seen like a new thing from this paper, or that's some paper like they did like higher molecular level studies after just having fine needle aspirations. Concerning on the size, of course, from a little experience we have here, it's like there are some lesions where like a deep-seated, maybe passing through vital structures. Some attendings prefer to use fine needle aspirations because the size of the needle is like 20 gauge, which has lower complication rates compared to core needle biopsy. That's all I can maybe add from a good question, good answers from Abiza.
Thank you.
Thank you very much, Dr. Abiza, and thank you everyone for your questions, your contributions. It was short, but very precise and very interesting. Thank you, Dr. Abiza, for a job well done. Again, I want to apologize that because of network issues, Dr. Judy is unable to join us. So I think in the absence of any further questions or any additional comments, we can end the meeting for now, yeah?
Yes. Okay, thank you.
Thank you.
Thank you everyone for joining us today. See you again next Thursday, same time.